to our third podcast of ISELP In Motion. We're going to talk today about the foot and the pastern, what we've learned and what's next. Obviously, one of the most important parts of the horse, and we're going to discuss that a bit in detail today. Our guests today are Professor Jean-Marie Denoix, who is well known, particularly among the ISELP people, co-founder of ISELP. And if I started to read out Jean-Marie's acronyms and alphabet soup at the end of his name, we'd still be here tomorrow. So we're going to limit that, but take it from me. He's very well accomplished and one of the best known anatomists and diagnosticians in the world, and certainly someone I count as a mentor. Our other person joining our podcast today is Dr. Roland Thaler. And Roland is a ISELP Certified Member and has been a clinician that I have known and worked with off and on for many years. Seen him at the ISELP modules, and he is now taking on working with the ISELP student program, and a very astute clinician and someone I've enjoyed working with as well over the years. So again, today we're going to look at the foot and the pastern, which is the foundation of equine locomotor pathology and locomotion, what we've learned to this point, and where the science is heading. Now, things have changed dramatically since I got in a pickup truck with my father and his vet pack, and we drove around, and we had some serious diagnostic armamentarium. We had a pair of hoof testers, and we had an X-ray machine that worked most of the time, and that weighed about 50 pounds, which at that time I weighed just a little bit more than it did. But I helped Dad drag it around, and we were able to look at radiographically what was going on inside the horse's foot. Certainly we use many more sophisticated views now, and of course we use a lot more technology and advanced imaging. So we're going to talk about that. But first, Jean-Marie and you and I have been talking about various aspects of the foot. Jean-Marie and I were talking just recently about that next year will be the 20th anniversary of ISELP, and when we started it at a meeting in Middleburg, Virginia. So we're looking forward to having Jean-Marie back to Virginia to commemorate that and next spring. So we'll look forward to that, Jean-Marie. But Jean-Marie, why don't you tell us a little bit about and talk to the listeners about why the foot and pastern matter from a biomechanical, anatomical clinician standpoint, why that foot and pastern matter so much.
But thank you, Ken, for the introduction and for the perspective of the 20 years anniversary of ISELP at your place. Why the foot and pastern matter? It is just because these are the closest area of the horse to the ground surface. So when the horse moves, all the stresses induced by or related to surface irregularities or horse movement, well, are taking place first in the foot and pastern. So this is the first interaction between horse and ground surface. And these areas are designed to absorb foot irregularities and to absorb high stresses based on the anatomy. And this is why we have in the foot and pastern a specific anatomy, and which allows the horse to do different types of movements, such as flexion extension, very well known, but also collateral motion and rotation induced by ground surface irregularities or exercise on turns. And this makes the foot, of course, predisposed to a lot of injuries involving the different soft tissue and bone tissue in this area.
And Roland, you know, you've obviously been a clinician many years and have seen a lot of different type of injuries and a variety of different types of sport horses. What do you see as some of the more common injury patterns, and if you want to break it down by discipline?
Well, my practice is predominantly hunters and dressage with some competitive jumpers. So it's really not too earth-shattering. I see a fair number of deep digital flexor tendon injuries, particularly just at the suprasesamoidean area above the navicular bone. I see a significant number of suspensory ligament injuries and collateral ligament injuries. So any kind of pathologies in the foot. The difficulty I've had is that most of my horses are overweight horses that probably have some degree of metabolic issue. They've been campaigned for quite a while, so there's a lot of complex multiple injuries through various structures. So very seldom does it come down to one structure, one injury. I usually have to go multimodality and treat a variety of structures. So I really try to approach these horses in a more holistic sense in terms of trying to encompass the whole horse, not just one structure, if that kind of approaches. And I think that's the biggest change. There was a period of time where I really tried identifying the most significant injury and trying to find a horse with one leg, one injury. And after 2 years of really trying to drill down hard on that, I could only find maybe a half dozen horses that had one leg with one injury. Almost every horse has multiple limbs, have conditions of multiple limbs, or in the affected limb have multiple conditions within that one limb.
And I think what you're saying is exactly correct. You know, you've got to look at the entire horse. Again, we do a lot of referrals for bone scans in our Northern Virginia practice. And, you know, when I go through what the findings are with the bone scans with clients, they'll go, "Oh my gosh, that seems like a lot of problems." And I said, well, they're athletes, they're sport horses. They work hard for a living. And they're going to have a variety of problems. You know, you may have a sacroiliac problem, a back problem, a forelimb problem, and then something in the hind limb. And again, until you deal with all of these in a holistic manner, you're not going to be very successful. If you just pick at one or two, you're not going to be very happy, and the client isn't going to be very happy because that horse just won't come right. And then, of course, the higher the level, you know, demographic wise, we see a lot of event horses in our practice. But it really doesn't matter whether you're talking about the Western performance horse or the English event horse. If you don't look at everything. And so Jean-Marie, many years ago, when I was out visiting Sorrel, and I was impressed that he not only looked at the horse in a very holistic manner, examined the feet, looked at the lameness issue, talked to the client, and every one of those horses went out with a diagnosis, a treatment plan, a shoeing plan, and where they were going forward from there. And that wasn't lost on me, and certainly that's the way I've continued to do that for the last 20 or 30 years. So Jean-Marie, why don't you talk to us a little bit about, you know, what your lessons have been as you've done this over a number of years on where you started with just kind of what I was describing and how it's progressed to using more advanced diagnostics, that sort of thing nowadays.
Thank you, Kent. Yes, of course. Well, I have progressively moved from an analytic point of view, you know, analyzing, as you say, the different part of the horse and the different problem of the horse and making a list of all of that. The problem that I had, you know, with experience and looking at horses at work was to discriminate what is significant or not. And this is the most difficult on horses because it is quite easy to make a complete diagnosis and while looking at osteophytes of the fetlock, proximal suspensory disease, neck problems, sacroiliac, as you said. But at the end, you have to identify the 2 or 3 most limiting factors of the horse. And this is the most interesting, you know, because every horse has several diseases, as you said, several problems, several injuries. But, you know, regarding the complaint of the rider, there are always, you know, 2 or 3 most significant problems limiting the use, limiting the training, and limiting, the result when the horse is competing. And in order to do that, you need experience of horses at work. And I found progressively that the clinical examination should be done very extensively and documented with video, for example, but you have also to look at the horse at work and see how the horse is dealing with his problem. Because I cannot consider that there is one completely sound horse. Every horse has different type of problem, as you mentioned, but you know, horses are able to work and train with this horse, with this problem. And the most interesting for us, in order, if we want to help the trainer, the rider, is to manage what is most significant and avoid misleading and doing too much imaging. I think that, of course, we did a lot of progress with advanced imaging, incredibly lot of progress about the documentation of disease. The problem is that imaging modalities are so sensitive now that we are going to do overdiagnosis. And at the end, it is not what you are going to see on MRI, X-rays, or CT scan, which is important. What is important is how the horse is dealing with the problem and identifying what need to be addressed in order to maintain the horse at the expected level of competition.
And I think, you know, one of the things I'd heard in the past, and they were talking about this with professional football players, and they'd say, well, what's the most, they talked to a very prominent coach, and they said, what's the most significant thing that has changed in football? And the coach immediately said, well, the MRI. He said, back when I started this, he said, there were no MRIs. You know, you took every player who had some issue and you just, you know, you wrapped them up and you did physical therapy. And then, you know, when they looked a little bit better, you threw them back in the game. And he said, now, you know, we can look at the problems and determine whether they're of no significance or whether they are of significance. And the horse needs an extended rehab, or the player. And so it's no different, I think, in our world. And I think it's just what you're saying is you've got to go ahead and pair up your physical exam, which is the single most important thing you do, your knowledge of the sport and what they're trying to do, and then what the rider is giving you as a complaint, and then marry all that information up to the imaging to make it worthwhile. And if you just run 100 horses through an MRI or a CT and try to sort out afterwards what the problem is with no physical and no history, you're going to be pretty dissatisfied with advanced imaging. It only works when you involve experienced clinicians in it. Now, Roland, to that point, obviously one of the things we haven't talked too much about here is diagnostic blocks, nerve blocks, and how do you utilize those in your practice to decide where you're going with a horse in as far as imaging or treatment?
Yeah, good question. And I think that's kind of that's the crux of everything. In my practice, any horse that I look at, I get objective gait analysis. I had been using the Equinosis system for a period of time. I recently switched over to the Arinos Equisim system. Happens to be French, Jean-Marie. And all part of that, and also includes a concurrent video taping of each stance or each stride. So I use gait analysis on every horse I look at, and I use that as a before and after, and I try to get rid of my subjectivity or predispositions towards a diagnosis, and I really try to use that to help me. And diagnostic anesthesia is just one part of the puzzle. It all has to fit, right? So we can get false negatives and false positives based on distribution of anesthetics. So I don't rely just on diagnostic anesthesia. I don't rely just on imaging. I don't rely just on history, but all of those have to come together along with the clinical examination to add significance to the blocking pattern. And I feel that I'm more accurate when everything comes together to one point. I feel pretty confident about what I'm finding. When there's a divergence of findings, then I know I need to dig deeper, or maybe that's all I can get done for today. And I've learned not to try to come up with the ultimate answer all at one time. Some of these you just need to work at and peel the onion back, so to speak, and I come up with a better answer.
Well, and I think that, what you're saying has a lot of relevance because, we want to find this problem as early as we can into the process because that's when we're going to have, as clinicians and treating the problem, the most success. If we're looking at these horses at end stage, if it's been lame 6 months, the odds are that we're not going to make a big difference from a treatment standpoint. Still possible, but the odds are against us. If we're looking at it early on, and let's say it's a fragment, and you'll see some of these fragments, say particularly in the fetlock. And many of these we look at and we say, oh, well, that fragment in the back of the fetlock, that shouldn't be bothering them too much down at the bottom of the sesamoid, because that's, again, what the literature says. But then, recently I had 3 cases in a row of osteochondral fragments at that exact location at the base of the fetlock, at the base of the sesamoid, in the back of the fetlock. And all 3 of those horses blocked IA. To it. So, obviously those 3 horses had not read that literature. And so, you've got to test the assumption, and you've got to try to intervene early if you can. And then, rehab, I have my favorite little saying is one that absent a diagnosis, surgery is trauma, alternative therapy is witchcraft, medicine is poison, and rehab is a waste of time. If you don't get that diagnosis, none of these other things are going to matter very much. And, that we've all seen horses that have come into us and they've presented with a whole lot of treatments done on them. We ask, okay, well, what's the diagnosis? We get this stack of paper we're looking at. What's the diagnosis? And the client goes, oh, I have no idea. That's why I brought it to you. That somewhere we've got to get better as clinicians and not just needle jockeys. It doesn't help to just keep injecting the horse and hoping that it gets better. You've got to be better than that. And I think we do take that approach nowadays. And Jean-Marie, you know, as you've done this, and many times we've had conversations, and you know, you've always taught me when we're doing ultrasound, you know, start with your reference image for an area, and you know, and additionally, you know, you're looking for soft tissue deformation. That's the best reason to go ahead and ultrasound a horse. But, you know, how have the anatomical landmarks helped you reshape techniques and approaches to ultrasound? I mean, you continue to amaze me that you come up with ultrasound techniques that none of the rest of us have ever thought of. And then you know, I'll have seen a module several times, and then all of a sudden we're doing it a new way. And, you know, where does that come from?
Yes, Ken, thank you. Just to continue before answering this question with
Sure.
you know, assessment of horses, I think that you know, we have to examine horses where they are considered sound by the trainer or the rider, and because you know, every horse has its own pattern of locomotion. And if we don't know the basic pattern of the horse when he is considered sound, it is difficult to identify subtle changes when the horse is becoming to present a problem. So this is why if we have the possibility as vet to examine horses, you know, when you are working in a stable, I think that don't examine only the lame horses. You have to try to convince people that real sport medicine consists in examining what is considered normal in order to be able to identify subtle changes when the horse will, well, begin with a problem. And I think this is a very interesting part of our job, and this is real sport medicine. Now, coming back to ultrasound, you know, the problem is that at first I was an anatomist, so well, I know most of the structures of the horse. And you know, my philosophy is that every type of anatomical structures can be injured in a horse. So my objective was to be able to document everything with ultrasound, because ultrasound is a wonderful technique which enables to examine the entire horse on the standing horse. And there is not a lot of techniques that allow that, and this can be done in the field. So my objective was to standardize techniques. And during 40 years, I use ultrasound now. And I have to tell you, Ken, that well, every year I improve. Because every year I try to find a better way to document a disease and to diagnose a disease. And of course, this is based on the knowledge of anatomy. And well, what I try to do at ISELP is to present to people, attendees, ISELP members, how to do new diagnosis and identify new disease that were no longer, that were not known in the past. And I began, you know, at AP presenting in 1995, so 30 years ago, presenting, you know, spontaneous injuries of the proximal check ligament in the horse, which was not known at that period. And I continue to try to identify new conditions. Because as you said, Kent, in the past, with only X-rays in the field with your father, it was probably difficult to identify all the soft tissue condition of horses. And nowadays, unfortunately, with the technological progress, we are more and more able to do that. But as I said, we are more and more able to identify everything on a horse. The drawback of that is overdiagnosis first, and the other drawback is to consider that every injury has a significance. No, not every injury has a significance. So not every finding has a significance. And going back to what you said, Kent, you have always to be back to the clinical exam in order to establish what is really significant and really helpful for the horse.
Yeah, and Roland, a question I had, and I get occasionally, and maybe you could answer this for me. When do you, initially, we were all doing weight-bearing ultrasound. And then, of course, more recently, we've all started doing non-weight-bearing. And where do you find the relevance and the change in doing more non-weight-bearing nowadays?
I think ligamentous structures, I'd like to see them non-weight bearing because I'd like to see a little relaxation so they're not being anatomically pulled in alignment. And more importantly, where I've really have a lot of interest is in Doppler or high resolution Doppler imaging on staging healing aspect of the structure. And so what I've been doing is I've been doing non-weight bearing imaging of structures, putting Doppler on them, and when I see a reduction in blood flow, then I start increasing their level of work.
Okay. And now, is there a time frame where you see more Doppler in the acute injury, and then does it, like you say, fade over time, or?
That's been my clinical impression, and of course that's subject to changes as I get older and I start seeing more and more and using it more. But I've always been torn between, if you rest a horse for 6 months or 9 months, they decondition so quickly, and then you try to rehabilitate these horses, and then you're so often now you have a big couch potato of a horse that you're trying to get back into work. The horse is overweight. The horse is trying to come back from an injury, and I think it complicates it. So I really like to keep these horses moving, and I like to return them back into work as soon as possible. And I've been using the blood flow or inflammation characteristics to help gauge that with palpation, with the symmetry of the horse. And I've been quite pleased with how well these horses have been able to come back, as opposed to just 10 or 15 years ago when I had a suspensory ligament injury and we rested them for 6 months before we return them. Now they don't get rest at all. They get hand walked for 30 days, and I start tack walking them until I see the vascularity go down, and then I return them back into more intense flat work and progressively into jumping. So my clients have been happy and the horse have been going well.
And Jean-Marie, follow up on that same topic, back to you. Have you been using Doppler more, and what's been your experience with it?
Yes, we have a nice experience with Doppler in steeplechaser horses having superficial digital flexor tendinopathies. And I agree with Roland that it is a very useful information, but the problem is that with Doppler, first, you have to standardize the technique because the Doppler signal is vary according to the machine, vary with the setting, and vary with the technique of the operator. So Doppler is a very sensitive technique, and there is a lot of inter-individual variation. I speak about the operator, inter-operator variation. So first, standardization is crucial with Doppler. And then, as Roland said, you have to do that on the flex leg. And regarding the results, we have done a study on that showing that horses that kept a high signal at Doppler were more predisposed to re-injury the superficial digital flexor tendon statistically. But in the horses that did well, we had horses who kept a quite high signal, high Doppler signal in the superficial digital flexor tendon without re-injury. So Doppler signal is a complementary information, but you have also to correlate that to the clinical exam and to the horse tolerance to exercise.
And a follow-on question to that, Jean-Marie, is have you tried or just had any experience with ultrasound tissue characterization, the UTC approach, where they're doing it and they're trying to look more at the different tissue types and how they're healing?
No, Kent, we were not able to use this technique, but regarding evaluation of a lot of tissue now, including, of course, the flexor tendon, I do now systematically a dynamic examination on the weight-bearing leg, for example. So I began, a recording of this of the images from the proximal metatarsus down to the fetlock area. And as the machine is doing 50 images per second, and as I am doing, this screening during 20 seconds, I can gain, 1,000 of images in 20 seconds. And ultrasound is probably the best technique to get so many images. And this is essential if you want to follow, the recovery of especially of the flexor tendon, because a priori we don't know what will be the area of the tendon which will heal faster, and the other one which will need more time to heal. So it's crucial to me for this specific disease, but I do that also for for suspensory ligament. It is crucial to have a complete recording from proximal to distal to the lesion in order to improve the follow-up of the recovery.
Yeah, and I think, the tissue characterization we see every time we're doing our ultrasound. Yes. And obviously you can affect that with weight bearing, non-weight bearing, a variety of different approaches and angles, and are you sagittal, are you transverse? And so there's a lot of different ways to do it. So even if you don't have a UTC unit, which I'm still wrapping my head around trying to figure out, how useful they really are against an experienced clinician and a systematic exam, as you've said. I think they're kind of actually even Steven. I think where they're dramatically helpful perhaps is more in the case of clinicians that may not have as much experience following a specific type of athletic horse. As we've all talked about now, the different approaches to it, and Jean-Marie, one of the things I'd ask you about, because you were a pioneer in this area, is in creating shoes that held a biomechanical advantage to the horse's foot, so that when we had, say, a deep digital flexor injury, we could change the shoeing to where we could have more support in that manner, or we could shift the weight to different structures. Now, you've had many years now of doing that and have been probably the most prolific biomechanical shoe designer in the world. Tell us your experience with that and where you see it going.
Kent, regarding foot and Pastern, so the area that we are considering today, there is no doubt that what I have shown today regarding the different bone and soft tissue injuries of the foot have a biomechanical origin. So if you want to manage that, you should consider, the changes in biomechanics. And the way to do that is to reconsider the trimming of the foot, the shoeing program, the exercise program, and the type of ground surface. So this is true that what I have designed as a corrective shoeing, is still useful, and I still continue to reassess the usefulness of this shoe. But the shoe is effective if the interference between the foot and the ground surface is adequate. And another way to improve the efficacy of shoeing is to work on ground surface. And I think that for the future, the biomechanics and anatomy of the horse will not change. But what is changing nowadays is the type of ground surface with artificial ground surface, wood chips, underwater surface, etc. The objective now is to identify the best ground surface in order to optimize the efficacy of the different corrective shoeing that are nowadays well established for different conditions.
And Roland, how do you, in your practice, how do you integrate? Obviously, it's great to have this knowledge on biomechanics and shoeing, but if you are not transferring that information and what you're hoping to achieve to the farrier, then, this becomes a real problematic area. How do you do that in your practice?
I wind up doing a lot of radiography in as part, even if I have a horse that say has a suspensory ligament injury, I'll still do radiography of the foot to give a basis, and I'll send the images to the farrier with my notes. And I have a specific set of notes, and I'll draw pictures or whatever needs to be done, and that's transferred to the farrier. Then I'll call the farrier and we talk about it. And that's pretty effective. The problem is sometimes it's still words, it's still language, and your intent sometimes doesn't get through to the person that's putting the shoe on. And if we have a failure of treatment, then what I'll recommend to the client is that let's schedule the farrier and me together, and we'll work on this together at the same time. And that's been really quite effective. But in general, I think that our practice really enjoys a terrific working relationship with most farriers in our area. And I think it's been a very beneficial communication. And it's not that I have all the right answers. The farrier, I respect them. I respect the job that they do. And if I may say I want this certain type of shoe, and they may come back saying that doesn't work on this horse, and that's okay. Then we'll come up with a different plan. It doesn't have to be my way. And so I think having a working relationship is what this is about. And we have to include the owner and the trainer all in that same relationship.
And do you try to do that once or twice a year where you're doing a set of balance films? What do you consider your optimum interval?
It depends. If a horse is brand new to the practice, I'll do it initially when they buy the horse as a baseline, along with a baseline assessment of gait. So I have that kind of the fingerprint, so to speak, of the horse's gait movement coming into the practice. And if the horse has a condition, or if the horse has a conformational challenge, then I'll repeat that as needed. I might go to twice a year. Or if the horse has a real issue, we might do it every 3 months. But in general, I would say these horses we try to do once a year.
Okay. So what I'd like to do as we wrap this edition up is ask each of you what you see in the future for as we're moving forward with Foot and Pastern, knowing all the different things. What's new? What's exciting to you? And where do you see that going? So, Jean-Marie, we'll start with you.
Well, except, new imaging technologies, I think that what we need now is to improve, the horse tolerance, the horse comfort when the horse is working. And I think that in the coming years, there is a need for more knowledge on the hoof, ground surface interaction. This has been partly investigated by different teams in the world, in Utrecht, in the USA, by Natalie. But we still have to consider, what is happening in different situations, in different type of sport exercises. Because till now, what is known is often done on standardized situation at slow speed. Now I think that we need, it's not easy to do, but we need to know what is happening at training speed and in competition. And I think that this is a main area for the future in order to understand the origin of the disease and to manage more adequately the problems.
Thank you. Roland, you?
Well, of course, I'm a bit more, have to be more practical about my application. I think I just have a leg cramp, excuse me. So I think one of the things I've been working on that I'm quite intrigued with is that typically when I take radiographs of feet for balance. I do them on 2 blocks in bilateral weight bearing. And now I've been going to 1 block, but I use a soft deformable block. So I have the horse stand on a block that's a little soft and kind of mimic the ground surface when the horse is traveling. And then I compare static on a hard block and the unilateral on a single block and try to come up with a rationale for trimming the horse most appropriately. And that's been quite interesting. I've been working on that in the last few months. And I think that they could have some real good, useful information for trimming these horses and working with them.
That's really interesting. For me, I think it's probably as much as anything as we've recently added a standing CT to our practice. And it's, just amazing to me. We'd certainly done 3-dimensional imaging for years with a standing MR, but there's a fan beam CT, and so you can evaluate soft tissue structures as well as bone, and you can see it in a 3-dimensional aspect, which is amazing. So that's been fascinating to me, and I think that I'm so busy collecting my most interesting case, I immediately move on to the next one. So I'm expecting to have a lot of fun with that over the coming year or so here. So I'd like to go ahead and thank you both for joining us. I think we've talked about some of the issues. Of course, there's so much in the foot and pastern that we can cover that 40 minutes won't really crack it, but we'll talk more in the future. Some other things I did want to mention is that our next episode that we'll do as a podcast is a bit more of the student training. Roland, like I said, is involved in helping our ISELP student program, which we're launching this year. And I think he'll have some insight, and want to thank Jessica Morgan also for working on that program, another ISELP certified member. And then additionally, Jean-Marie will be in Australia early next year in February 19th, 20th, 21st, and going to do the ISELP module on foot and pastern. So Jean-Marie, I don't know if I'll make that one. That's a good ways down under, but I'd love it if I could. But I think that'll be fascinating. And Jean-Marie brings, 18 hours of fascinating lecture on that module, as well as the wet lab. So we'll look forward to all that. And thank you for joining us on ISELP In Motion. Until we do this next time, thank you. Keep moving forward. Thank you, Roland. Thank you, Jean-Marie.
Thank you, Ken. Thank you, Roland.